Hello and welcome to a Health Podyssey. I'm your host, Alan Weil. Much of the onus for advancing the value-based payment agenda has fallen on primary care physicians. Recognizing the critical role of primary care, there's been a proliferation of innovative payment models, extensive efforts to measure quality, and major investments in things like electronic health records built around accountability of the primary care clinician. But in this context, it's easy to forget that spending on specialty care is more than 3 times that of spending on primary care. And of course, as we well know, specialty physicians earn far more than their primary care counterparts. So if our goal is to pursue value and accountability in healthcare, specialty physicians need to be part of the equation. So how do we get that to happen? That is the topic of today's episode of A Health Podyssey. I'm here today for a special recording with Liz Fowler, Deputy Administrator of CMS and Director of the Center for Medicare and Medicaid Innovation, known as CMMI. Dr. Fowler and colleagues recently published an article in Health Affairs Forefront focusing on specialty care. We'll discuss CMMI's approach to this topic in our episode. Dr. Fowler, we've known each other for a long time. I hope it's okay if I call you Liz. Liz, welcome to the program.
Thank you, Alan, and please do call me Liz.
I will. Great. So I set just a little bit of the stage, but I do think it would be helpful if you started by giving our listeners a sense of why not only we need to think about specialty care, but why we need to have a distinct strategy for moving specialty care into accountable care models.
Thanks again for the chance to be here. I really appreciate the opportunity to highlight some of the CMS Innovation Center's recent work, and particularly our specialty care strategy, which, as you noted, was in the Health Affairs Forefront back in April. So stepping back, we've outlined a vision for a health system that provides person-centered, team-based care that meets people where they are and provides a better care experience overall. We know that doesn't happen today in a system that sometimes, or even often, provides fragmented, uncoordinated care, which is why, as part of our strategy refresh that we laid out in 2021, we set a bold goal for 100% of Medicare beneficiaries and the vast majority of Medicaid beneficiaries to be in an accountable care relationship by 2030. That means a health provider or practice is accountable for the quality of their care and total cost of care. This advanced primary care physician or an ACO gives patients a quarterback, someone who's helping them navigate the system, coordinate their care with other providers they see, including preventive services, stay out of the hospital, avoid unnecessary readmissions, etc. But team-based accountable care is not just about primary care, as you noted. To make continued progress towards our 2030 accountable care goal, we need to focus on better integration of specialty care and primary care. And that's because delivering person-centered care really requires addressing the full range of patients' needs. And providers coordinate with 80% more physicians than they did 20 years ago. Plus, specialty care is a big part of overall spending. So I might describe the strategy as specialty care integration. And there might be particular areas of specialty care, for example, conditions like ESRD or cancer care, where it might make more sense for specialists to serve as a quarterback for their patients' care rather than a primary care physician. But really, we were thinking about it more comprehensively. And so that's why in 2022, we laid out this strategy for specialty care coordination and integration. And we're continuing to execute on this strategy. So the podcast is really well timed.
I appreciate that introduction and particularly the note that specialists, they play many roles, but one important differentiator is between sort of the episode of the specialist intervening in someone's life around a critical issue, and the other is more continuity, where you have a chronic condition that's really managed in some instances by a specialist. And we need to have those both in mind as well as others, but that's a great opening. So obviously people who want the full detail should look at the April piece in Forefront, but if you could just say a little bit about the specialty care strategy at CMMI, that would be great.
Sure, I'd be happy to do that. In a nutshell, the strategy has 4 components, and each supports our accountable care goals. So the first is around data transparency on specialty care performance. So sharing data on specialists who provide high quality, lower cost care can inform referral decisions and help primary care practitioners and ACOs manage care for their patients. One example, earlier this year, the Innovation Center started sharing shadow bundle data, that's claims data for services, suppliers, and their associated payments to ACOs. And this gives those ACOs insight into specialist care patterns, supporting their management of their beneficiaries' specialty care needs, and giving them the ability to make comparisons on cost and quality across specialties. The second element is on maintaining momentum on bundled payment models. So building on our comprehensive joint replacement model and the bundled payment model tests, we recently proposed a new mandatory episode-based payment model, the Transforming Episode Accountability Model, or TEAM. If finalized, this model will start in 2026 and focus on 5 surgical episodes. We got over 2,000 comments on the proposed rule, and we're currently sorting through all of those and anticipate putting out a final rule this fall, which hopefully will give hospitals plenty of time to prepare. The third element is focused on driving better communication and coordination between primary care physicians and specialists on behalf of their shared patients. We know the financial proposition for specialists to stay in fee-for-service is strong, and the aim here is to better engage specialists in value-based care arrangements. Tools like e-consults and enhanced e-referrals can help drive better coordination and communication in our advanced primary care models, and we're exploring establishing financial targets for high-volume, high-cost specialty care. And then finally, the final element is about creating financial incentives for specialists to affiliate with ACOs and move towards value-based care. And here we're considering a few different levers we have, including targeted financial incentives for actively managed specialty care. Each component is something we're working on now, and we aim to advance specialty care integrations through really a carefully calibrated portfolio of models and initiatives that are consistent, like I said, with our accountable care goals.
So when I think about the evolution of the move to alternative payment and accountability, it seems to me like primary care has been at this for a longer time. We have broad expectations, keep the population healthy, registries, just so many payment approaches designed to guide the primary care clinician into this value framework. It feels to me like we're less well developed when it comes to specialty care. We have some bundles that kind of make sense, some episodes. Yes, you're accountable here and there. And then there's sort of on the commercial side, there's sort of find the low cost provider, but since in Medicare you have a fee schedule, that's not so critical. So when you think about building an agenda for specialty care, what are some of the unique challenges? And of course, we like to think of opportunities when it comes to approaching value for the specialist relative to the primary care clinician.
Let me start with a couple of general reasons why value-based care for specialists and specialties poses a greater challenge than for primary care practitioners. As I mentioned, the financial proposition for specialists to stay in fee-for-service is very strong. Current Medicare payment policy, the physician fee schedule, are all weighted more heavily towards services and procedures provided by specialists. The financial rewards of volume-based payment make value-based care a challenging proposition from the start. And then on top of that, there may not be adequate or appropriate quality measures for many specialties or the care that they deliver. And related to that, perhaps another challenge, as we've implemented MACRA, that's the federal law that governs physician fee schedules in Medicare or physician payment, we have a circumstance where specialists are often getting payment increases or decreases based on quality measures that really aren't relevant to the type of care that they provide. These providers are lumped in with multi-specialty practices that are rated on measures that aren't really tailored to specialty care. And it's true, we've tested payment models for specific conditions and diagnoses. I mentioned earlier the kidney models that work closely with nephrologists, oncology models for patients undergoing chemotherapy. In these instances, it may make more sense for specialists to provide that quarterback care for patients, but not every specialty or disease can have a separate payment model. Doing that would just replicate and perpetuate the current fragmentation we see in our health system and really doesn't solve the problem of integration. It's also the case that we've been testing episode-based payment models. So we talked about that a little bit. And one thing we heard from multiple sources is that having those separate episode models creates conflict and conflicting incentives and administrative complexities with accountable care and primary care models. Technical changes like attribution, setting benchmarks in silos. We've tried to tackle those challenges in the team model I just mentioned. And we've thought about how these surgical episodes could be integrated with ACOs and primary care. It's one of the reasons we proposed a 30-day post-discharge window in this episode model. We want those patients to go back to primary care sooner and for better and more comprehensive care management. Accountable care and primary specialty integration are models of care and payment systems built around patients rather than specialists. So I think that's a reason to sort of step back and think more broadly. I'll maybe make one final point about the challenges that we faced. As we're moving towards a payment system that is person-centered and team-based and integrated and more upstream, rather than waiting for patients to be hospitalized, we're thinking about the role that mandatory models can play. So primarily the Innovation Center has tested voluntary models, and those largely benefited providers who joined when the conditions are favorable and then they drop out when they're not. A mandatory model approach provides an opportunity to expand the reach of accountable care. So we think that the health system is ready for this type of mandatory model and may be actually expecting us to move in this direction. Even so, we're committed to making sure that any mandatory model is responsive to feedback, while also strengthening the value-based care landscape for beneficiaries.
So as I think about the approach you're taking, you mentioned twice now the incentive for specialists to stay in fee-for-service, which I completely understand. So it seems to me like there's almost a little bit of a power imbalance here. We're expecting a lot of primary care, and then we have these great hopes to bring in specialty care, but it feels like they hold sort of more of the cards. So if you're trying to make this integrated, how do you align so that it doesn't sort of feel like, oh, please come join my initiative here. It's good for me. Maybe it's good for you. How do we make this a little bit more seamless or more attractive, I should say, to all sides of the equation?
That alignment between primary care and specialty care is really important. Let me give you a couple of examples of how we think about this. First, I mentioned the shadow bundle data. Going one step further, for primary care practices that are participating in a model that just launched on July 1st, the Making Care Primary model. It's a 10-year primary care model in 8 states. We're sharing data on specialist performance. So for the first time in an advanced primary care model, we'll directly give primary care organizations tools to improve care coordination with high-quality specialists through access to data dashboards, model-specific interprofessional consultation, and co-management billing privileges. We're testing a new billing code in this model to encourage specialists to work with primary care physicians by allowing them to bill for care coordination. The new code is intended for patients that require both longitudinal primary and specialty care to stabilize a new or exacerbated chronic condition. And then to move upstream in the patient's journey and offer more opportunities for specialists to participate in advanced alternative payment models, we're also designing a model to complement our primary care models. And this is just hot off the presses and brand new, but using a simple approach that doesn't interrupt or overcomplicate clinical practice on the ground, we're exploring opportunities to build on the MIPS value pathway framework. The MIPS is part of that MACRA legislation I mentioned, because this value pathway framework offers an already existing reporting and measurement pathway for cost and quality that's relevant for specialty care. So MACRA created MIPS as a way of tying clinicians' payment to some cost and quality measures. And like I said, clinicians aren't always measured on the things that are relevant to their practice. To address that concern, back in 2020, CMS launched a new reporting option, this Value Pathways, to allow clinicians to report on measures that are more directly relevant to their clinical practice. It's a promising mechanism to engage specialists in upside and downside risk. And these MVPs, as we're calling them, offer an opportunity to drive a range of clinicians' of various specialty types into value-based care. So as we're thinking about building our specialty strategy, there might be an opportunity to test and strengthen the MVPs to make them more meaningful. So a model based on the MVP framework means the Innovation Center can make adjustments based on provider feedback and bring more specialists into value-based care in a way that doesn't require a separate new model. So this new ambulatory specialty care model concept is intended to directly engage specialists in meaningful value-based payment and increase the number of primary and specialty care arrangements. So we're seeking input on this approach and others as part of the physician fee schedule proposed rule that just came out.
Well, this is a great overview of the approach you're taking. I want to ask you now some questions about sort of how this fits into some broader health system issues. We'll tackle those questions after we take a short break. And we're back. I'm speaking with Dr. Liz Fowler, Director of CMMI, the Centers for Medicare and Medicaid Innovation, about the new strategy around specialty care. We've covered a lot about what the strategy looks like, and now I want to turn to some issues of sort of health system context. So let me start with a question. You may feel like you've already answered it, and if so, you'll just say, I've already answered that. But when I think about healthcare, I want to differentiate slightly between sort of alignment and actual clinical integration. So we see a lot of alignment going on. You're part of my system. But then there's true clinical integration, which drives better outcomes and hopefully better patient experience. So I'm trying to listen to the various models you've described and think about the degree to which they take us beyond alignment into actual integration. I was thinking about the data sharing provisions you described or some of the alternative payment approaches that you're getting new input into. Can you just help me think about the degree to which these initiatives are actually going to push toward clinical integration?
Thanks, Alan. And as you've noticed, I can spend most of the day talking about these topics. So I'm really happy to have this conversation. So as I mentioned, our accountable care strategy envisions a more seamless set of transitions between primary care and specialty care clinicians, so that pivots between chronic care and acute episodes aren't fragmented and are better managed on behalf of patients. We want to incentivize that better coordination across and between primary and specialty care to co-manage the patients that they share. The strategies I outlined that we're pursuing under Making Care Primary is an example of how we're thinking about testing and promoting better coordination and communication. And as we begin the design of this new ambulatory specialty model that I just mentioned, we're considering how to reward specialists for improving integration with primary care. And we're seeking specific input on that as well. Aside from the episode payment model, a lot of our current effort is focused on how to do a better job for patients in the ambulatory setting. And so for patients in outpatient care, making sure that we're not only holding specialty and primary care practices accountable for cost and quality, but actually integrating them, as you said. In the long term, we want to build a cohesive measure set for different specialists, whether they're part of an ACO or not, and then tie to integration with primary care. One of the first steps is getting the measures lined up with the specialty practice and the comparison and benchmarks to be meaningful enough to drive improvements. No matter where a patient seeks care or where they go for care, that providers are operating under a set of value-based incentives that prioritize quality, outcomes, and costs. So under our accountable care and specialty strategies, it's not just a single model that will accomplish that, but how do we get providers working together for patients? It really is a longer road. I wouldn't say that we've got it all lined up and we have all the answers, but I think we're starting to build that, the pieces that we think will lead to that clinical integration.
So now I'm going to ask sort of the flip side of this question around integration. We've published a lot in Health Affairs about how horizontal consolidation, the multi-specialty physician practices or all of the orthopedists coming together and forming a single practice, it drives up prices. Now, that's a commercial market problem. It's not a Medicare problem because you have control over prices. But when you talk to the leaders of those practices, they say, well, we have to consolidate to handle what you're expecting of us. We have to bear risk. We have to collect a lot of data. We have to analyze it. And we need to be participating in these accountable models. In order to do that, we need scale. So I'm curious, when you're sitting in CMMI where you don't have to worry about prices per se, how do you think about whether your models are pushing the delivery system to engage in behaviors that could actually end up costing more for private payers because you're encouraging consolidation?
We think that competition and value-based payment can coexist and, in fact, complement each other. Financial incentives that drive organizations to deliver better care at lower cost, whether they be large integrated systems in highly concentrated markets or small organizations in competitive markets, can transform the health system and move us away from volume and towards value-based care. And it's really that volume-based fee-for-service payment system that's at a root of a lot of the dysfunction in our health system. So some have asked whether value-based care has driven consolidation. I don't know enough to answer that question, but my instinct is that it is not the driving force. Some studies have suggested that value-based care is a factor, but consolidation in healthcare, both vertical and horizontal, was happening before the push to value-based care. And if you look at the proportion of payments in value-based payment arrangements, I don't think it's enough to drive these trends. On the other hand, I think you could make an argument that aligning financial incentives across providers, health systems, and payers might obviate the need for a consolidation. And I can say that some of our models have provided a specific path for new entrants, which has brought competition where there hasn't been much before. The kidney care space, for example, has historically had limited competition. Now there are competitors who are helping to improve care for patients with chronic kidney disease, with financial incentives to keep people from developing ESRD and providing more dialysis in the home setting. I think there's a legitimate question to ask, and you sort of touched on it. How much risk is needed to drive the incentives towards better care without requiring this sort of need for a larger system or, more investments, more consolidation? But I don't feel like I have enough authority here or enough knowledge to speak with authority, so I don't want to get myself in trouble. But that's, in a nutshell, how I think about these issues.
I was going to say I try not to editorialize too much in the podcast, but my listeners may disagree. So first of all, I really appreciate the notion that, because I hear the story that we have to consolidate for all these reasons. I think there's a lot of evidence to suggest that that's one of a number of factors and maybe often not the dominant one. But I'm really struck by the second part of this answer, which I want to think about more. The notion that if we do this right, true value-based payment actually could be pro-competitive by loosening some of the ties to the fee-for-service model that have then created rigidities around who delivers what care. And that if we could step far enough away from the fee-for-service structure that underpins so much of these payments to really pay for outcomes, that creates opportunities for technology-based solutions, for peer-led solutions, for swapping out expensive physicians with other personnel in the system. And if they can show that they can get the results, that really shakes things up with a pro-competitive lens. Now, I think we're a long way from seeing that evidence play out, but I really like that as an image. And it's very helpful for me in thinking about how we track the implications of these models. So I really appreciate that answer. Well, as we come toward the end of our conversation, I want to ask a question about sort of going back to your earlier comment about how it's easy for specialists to stay in fee-for-service. You're at CMMI, you're looking at models with respect to Medicare. Specialists are also practicing and are paid by commercial insurers. They're paid by Medicaid. But there's also, and we've had this conversation before in other forums, there's also Medicare Advantage where there's a whole different set of rules. So I'm curious how you think about where are you guiding specialists? And the more you have models within traditional Medicare, then there's Medicare Advantage, and there's commercial insurance. How does a clinician think about where to put their bets, how to make sure that they can be available to their patients regardless of which type of coverage they have?
As part of our strategy refresh, we prioritized a multi-payer alignment. We know it's really hard for practices to move towards value-based care when a sizable portion of care is paid for through volume-based fee-for-service. Providers tell us it's like having 2 feet in 2 different canoes. And although our 2030 accountable care goal is focused on Medicare beneficiaries in traditional Medicare, we're seeking to understand more about how providers are paid in Medicare Advantage and whether there might be opportunities to promote value-based payment in MA, the Medicare Advantage program. To promote multi-payer alignment, we're trying different ways to work with other payers. For example, in Making Care Primary, the model I've mentioned a couple times, we are in active partnership with state Medicaid agencies to align support for primary care across Medicare and Medicaid, and it's in those 8 participating states. In fact, we only launched the model in states where the Medicaid agency agreed to work with us and align with us. And we've also been working in those states to bring commercial payers on board. We also have the ambitious AHEAD model, which proposes a complete restructuring of health system spending across all payers in a state or region, meaning Medicare, Medicaid, and commercial or private payers. We also have the Healthcare Payment Learning and Action Network. We have engaged with 4 states through the State Transformation Collaborative, which has involved stakeholders in a state coming together and telling us what their priorities and goals are. So we're a seat at the table, but not necessarily driving the conversation. And then we've also formed a national payer working group through the LAN. And then the Innovation Center is also a signatory to the CMS Universal Core Measure Set to align quality measures across CMS programs, Medicare, Medicare Advantage, Medicaid, and then marketplace plans. It's a really important issue, and it's one of our top priorities, but I have to be honest, it's probably one of the most challenging, is sort of in a highly fragmented system trying to get everyone moving in the same direction. But we're hopeful that we're able to make progress.
Well, I don't want to end the podcast on the most challenging thing, so let me throw out one last question for you. What I always love about our conversations is that you're very deep in the technical side on payment, and that's very provider focused. But overlaying all of this is the patient experience. And so I wonder if you could just contextualize the entire conversation we've had with a little bit of a vision from the patient side so that it's clear to our listeners that this is, yes, you're moving around a bunch of levers and knobs that are directed at providers because that's the leverage you have. But overarching this is a vision for the patient, and I think it would be good to end there.
Thanks, Alan. And this is a favorite topic. And let me tell you, the way I explain it, when I first got to this job, and would bring issues before our administrator, Chiquita Brooks-Lister, and she would stop and say, "Wait, what does this mean for the patient? What are you trying to do for the patient?" And it was a reminder that we really have to ground all of our work in really how are we making this a better healthcare system for patients and easier to navigate. And I think that is the difference in this sort of accountable care strategy that thinks about integrating care. It's less about, is there an opportunity for specific providers to come in and out of models, but really about the patient care experience. And that's why we've committed to incorporating patient experience measures in all of our models and really tried to think about how the pieces fit together and really putting that patient at the center of our policy and how we're thinking about the models that we test, the initiatives that we're driving, and the end result. The end result really should be that patient-centered, team-based approach that meets patients where they are, maybe delivers more care at home, but really centers the patient at the heart of what we're trying to do. And I think it's a really important reminder. So thanks for ending on that important note.
Well, Dr. Fowler, thank you for all you're doing to try to improve care for Americans. You bring a wealth of experience and knowledge that really comes through in the conversation. Thank you for being my guest today on a Health Podyssey.
Thanks for having me, Alan.
Thanks for listening. If you enjoyed today's episode, I hope you'll tell a friend about a Health Podyssey.